Hello everyone. To introduce myself, I am Dr. Resham Vasani. So let's first begin with a short introduction. I am, as I said, Dr. Resham Vasani. I am a consultant dermatologist at Matunga. I have been associated with the KJ Somaiya Medical College as a faculty for 10 years and I have just left it in 2020. And right now I am also attached as a consultant dermatologist at the BG Vadia Hospital for Children. My core interest is clinical dermatology, and that brings me here on Unacademy. On Unacademy, I've been associated since the past 1 month, and I have a complete course of dermatology on Unacademy, which spans 19 hours. It started off on July 19, 2020, and it ends on July 31st, 2020. It's a course which completely covers the theory. It covers multiple images. It covers case scenarios and AIIMS type questions as well. So if you wish to enroll to this particular course, do use my referral code, that is Dr. Resham 10, that is DRRESHAM 10, and get a 10% off. I hope and wish to see you there. Now let's begin with the image-based MCQs. Okay, so now let's go to the MCQ 1. Before I start off, a disclaimer. Most of the MCQs the images have been taken from the slide set which belongs to the Indian Association of or IADVL, that is Indian Association of Dermatologists, Venereologists and Leprologists, and many slides have been taken from the net as well, and wherever possible I have tried to acknowledge each image. Okay, so now let's begin. So now this patient presents with flaccid bullous lesion which involves the oral cavity and the skin. He has a lesion that is shown in the picture below. Acantholytic cells are seen on the Zank smear. So they have asked you what is the most probable diagnosis. Now if you pay attention to this MCQ, they have mentioned certain things, like they have mentioned that the patient is having flaccid bullous lesions. Okay, flaccid bullous lesions is important, as well as if you see the picture, the bulla. What is a bulla? A bulla is a blister, or it is a fluid filled cavity which is measuring more than 1 centimeter in diameter. And as you can see here, the blister is flaccid. Okay, it's not tense, it's flaccid, right? So that is one clue. One, it's a flaccid bullous lesion. Second, it's involving the oral cavity and the skin. So what's the importance of knowing that? Okay, the importance of knowing that is the antibodies are directed towards desmoglein 3. That is what it is telling you. Why? Because when the oral cavity is involved, that indicates that it is desmoglein 3 involvement. Antibodies are developed against desmoglein 3 because desmoglein 1 is not expressed in the oral cavity, while desmoglein 3 is expressed in the oral cavity. Right? So when there are antibodies which are developed against desmoglein 3, which happens in pemphigus vulgaris, you get oral cavity lesions as the first manifestation, and concomitantly you do get lesions on the skin, and there will be a flaccid blister. Now why that flaccid blister comes in is what I will explain to you in the next slides. But also, if you see, they have given you another clue that there are acantholytic cells which are seen on the Zank smear. Again, this is a clue that it is a case of pemphigus vulgaris that we are dealing with, and hence the correct answer in this MCQ is pemphigus vulgaris. Now just let us go to a few details about pemphigus vulgaris. Now this is our epidermis, okay, and below it is the dermis. Now as you can see, this particular epidermis is composed of the enucleate layer with the first layer, okay, which is the tough layer, the enucleate layer, which comes directly in contact with the environment, and that is the stratum corneum. Below it comes the stratum granulosum. Okay, why granulosum? Because the cells are containing granules. These dots that you can see, they are granules which are called as the keratohyaline granules. As you can see, the cells of the granular cell layer, they are slightly oblong in shape, versus the cells of the spinous layer, which you can see are polygonal in shape, and these cells, they are attached to each other by these spines. So what are these spines? These spines are nothing but the intercellular adhesions. Okay, and these intercellular adhesions are called as the desmosomes. Okay, and below the spinous layer is the basal cell layer, which is columnar in nature. You can see the shape of the cells, it's columnar. Okay, and just below it is the dermoepidermal junction, which finally attaches itself to the dermis. Okay, so now let's pay attention to this layer, which is the spinous layer. As I talked to you, this spinous layer is containing spines, okay, or these intercellular adhesions, and these intercellular adhesions, as I said, are called as desmosomes. Now these desmosomes, they contain certain proteins which are called as desmogleins. So these desmogleins are of two types, desmoglein 1 and desmoglein 3. Now the desmoglein 1 is expressed in the most superficial layers of the epidermis, while desmoglein 3 is expressed in the suprabasal layers of the epidermis. What happens in pemphigus vulgaris is that there are antibodies which are developed against desmoglein 3, right? And remember, desmoglein 3 is expressed in the oral cavity. Desmoglein 1 is not expressed in the oral cavity. Hence, when there are antibodies developed against desmoglein 3 in pemphigus vulgaris, you have erosions and blisters in the oral cavity as well as on the skin. Now, what will be the location in the skin? The location in the skin will be suprabasal, because the desmoglein 3 is expressed in the suprabasal layer. Okay, so it will be in the lower spinous or just immediately above the basal layer. So you get a flaccid blister in cases of pemphigus vulgaris. What is the roof of the blister? The roof of the blister is a part of the epidermis, the part of the granular layer and part of the stratum corneum. That forms the roof of the blister. So it's just a very thin roof and it will not be able to sustain the pressure of the fluid, and hence it is a flaccid blister. Okay, so intraepidermal blisters are flaccid blisters. Okay, so that explains why do we get lesions in the oral cavity in pemphigus. That also explains why we get a flaccid blister in pemphigus. Now let's move ahead. This is a histopathological picture. If you take a biopsy of the lesion that the lady had, what you will see is something like this. Now understand here that there is an entity which is called as pemphigus foliaceus. It's a variant of pemphigus which is superficial. What actually happens in pemphigus foliaceus is there are antibodies which are directed against desmoglein 1. As I said that the desmoglein 1 is not expressed in the oral cavity. So patients of pemphigus foliaceus do not have oral lesions. They will just have skin lesions, correct? Now, if you see in pemphigus foliaceus, the blister is very superficial. Where is it? It is situated somewhere here. Okay, it is situated in just below the stratum corneum, correct? So when the blister in pemphigus foliaceus is situated immediately below the stratum corneum, it's going to be very fragile. Okay, it will not even be flaccid, it will be very, very fragile. So most of the times in cases of pemphigus foliaceus, you don't see any active blisters. Most of the times you just see scaling and crusting, okay, and few erosions. That's all that you will see. In pemphigus foliaceus, the distribution is classically present in the seborrheic distribution. So when you see scales, crusts without associated oral involvement and erosions, okay, then you should think of pemphigus foliaceus as the diagnosis. So now let's go to the histopathology. Okay, so this, I'll give you an idea about what is going on here. See, this layer is the stratum corneum. Okay, below that, this particular layer, which is deeply violet in color, is the stratum granulosum. It stains deeply because of the granules, okay, the keratohyaline granules. So this is the stratum corneum. This is the stratum spinosum, and this is the basal layer. So where are you seeing this cleft? You are seeing this cleft immediately above the basal layer, correct? So immediately above the basal layer, you will see a blister cavity, and within the blister cavity, you will notice that there will be acantholytic cells. I'll explain to you what are acantholytic cells. So please understand that in pemphigus, you are going to see a suprabasal blister or a suprabasal bulla or the blister cavity, which is filled with acantholytic cells. Now, why are the basal cells not involved? That is because the basal cells, they are attached to the underlying dermis with a structure which is called as hemidesmosome. And in pemphigus, there are no antibodies that are produced against the hemidesmosome. So, the basal cell layer is going to stay intact. It's going to remain attached to the underlying dermis, and it will form the floor of the blister cavity. Okay, and it will give rise to a row of tombstone appearance. Okay, which is very classical for pemphigus vulgaris. Now let's see what happens in pemphigus foliaceus. Again, let me give you an idea about what's going on here. This is the stratum corneum. Below that, this is part of the stratum granulosum, and immediately below that you can see that there is a blister. Okay, and the floor of the blister is formed by the stratum spinosum. Okay, so this is a subcorneal blister along which is containing these acantholytic cells. Okay, so that is the difference between pemphigus vulgaris, where you get a suprabasal blister, and in pemphigus foliaceus you get a subcorneal blister. That is the reason in pemphigus vulgaris you will get a flaccid blister, while in cases of pemphigus foliaceus, because the blisters are so superficial, most of the times they are ruptured on their own, and what you end up seeing is just erosions and scales and crusts. Is that clear? Now let's go to the third. This is a very beautiful histopathological picture. So here what we see is that this is the suprabasal location of the blister cavity, and you see these multiple acantholytic cells, and as you can see, these basal cells, they are completely adherent to the dermis, and they are arranged in a row of tombstone like appearance. Okay, so this cliche you need to remember. Okay, the row of tombstone appearance is what you see in pemphigus vulgaris. Okay, and this happens because the basal cell layer is attached to the underlying dermoepidermal junction through the hemidesmosome, and there are no antibodies which are produced in pemphigus against the hemidesmosome. Okay, also now see, I'll just explain to you with a small diagram out here. Okay, what happens in pemphigus vulgaris? See, if this is your cell, okay, these two cells, okay, this is another cell, and see, this is another cell out here. Okay, they are polygonal in shape. Okay, and they are attached to each other with these desmosomes. Now what happens is that because there are antibodies which are formed against the desmoglein, the desmosome is destroyed. So when the desmosome gets destroyed, what will happen to them? They will not maintain their shape, correct? So these cells, they were like this. Okay, they will not be able to maintain their shape, and hence they will get converted into cells which are going to be rounded. So the polygonal shape is lost, and the cells, they tend to become rounded. In addition, because they become rounded, what happens is, because they become rounded, what happens is they will have a huge nucleus, okay, in the center, and they will have peripheral condensation of cytoplasm. So this is what is called as an acantholytic cell, and this process of separation of the keratinocytes from each other because of the damage to the intercellular adhesions or desmosomes, it is called as acantholysis. So this is the classical acantholytic cell. This is the classical acantholytic cell that you see in cases of pemphigus. Okay, so this is the acantholytic cell that you see. As you can see, it is a rounded cell. It has a huge nucleus, and there is a peripheral condensation of cytoplasm. Okay, so this itself can come to you as an image-based MCQ. Okay, so this is a Zank smear. What is a Zank smear? What they do is that they will just remove the roof of the blister. They will scrape the base, put it onto a slide, stain it with Giemsa, and look out for the presence of acantholytic cells. So the acantholytic cells in cases of pemphigus vulgaris, they are going to be rounded, while the same in the cases of pemphigus foliaceus, they are going to be slightly more oblong, because the keratinocyte which is forming the acantholytic cell in cases of pemphigus foliaceus is the cell which is belonging to the stratum granulosum. The cell in the stratum granulosum itself is slightly oblong. Okay, so when it forms an acantholytic cell, it's going to form slightly more oblong than this kind of a acantholytic cell of pemphigus vulgaris. Okay, now let's see what happens on the direct immunofluorescence. Now on direct immunofluorescence, first of all, what is direct immunofluorescence? Now if you have a patient of pemphigus vulgaris, as that lady who was the question in our question number 1, if you want to do a bedside investigation, what will you do? First thing that you will do is a Zank smear, correct? Now, second thing, what will you do is the histopathology, which is going to show you the classical suprabasal blister with the presence of the row of tombstone appearance, okay, and the presence of acantholytic cells in the blister cavity. Now, to substantiate the diagnosis further, you can do a direct immunofluorescence. So, what is a direct immunofluorescence? It will tell you which antibody is getting deposited at what level, okay, and that gives us a diagnosis of where the antigen antibody reaction is happening, and that will give you the diagnosis of the condition. So in pemphigus vulgaris, the antigen is the desmoglein 3. Where is desmoglein 3? It is in the suprabasal location. What is the antibody? It is IgG. So in pemphigus vulgaris, you see that there is immunofluorescence which is intercellular, because where are the desmogleins? They are in the desmosomes. Where are the desmosomes? They are in between the cells, correct? So in pemphigus vulgaris, you get intercellular fluorescence, which gives a typical fish net pattern, because it is lace-like, net-like, right? So you have a fish net pattern, and this fluorescence is concentrated in the suprabasal location, correct? So what antibody do you see? What deposition do you see? You will see that there is deposition of IgG and C3, okay? So intercellular pattern with deposition of IgG and C3 in the suprabasal location are the findings of direct immunofluorescence in pemphigus vulgaris. Hope that's very clear. Next, there is a sign in pemphigus. Okay, there are multiple signs. There are 3 signs that you need to know very thoroughly. The first sign, it's called as the Asbo-Hansen sign. So what's the Asbo-Hansen sign? What if suppose if there is this blister, okay, and on this blister, if you apply vertical pressure, what is going to happen? The blister is going to expand, correct? Now, so to kind of document that, what you do is first you mark the margin of the blister, and then you apply vertical pressure, okay? Vertical pressure is important in the Asbo-Hansen sign. That's what you do. So here you apply vertical pressure, and then you see the extension of the blister to the adjacent unblistered skin. Okay, so that is called as the Asbo-Hansen sign positive, where you see the extension of the blister to the adjacent unblistered skin. Okay, so it is going to be positive in both intraepidermal as well as subepidermal blistering conditions. But when it gets extended in an angulated fashion, that is suggesting that the blistering that you are dealing with is intraepidermal. While the same problem, when it happens rounded, when the same extension happens rounded, that is suggesting that the blistering that is present is subepidermal. Okay, because whenever it's a subepidermal split, you get a clear kind of a there is a clear interface between the epidermis and the dermis for the fluid to get accumulated. Okay, so that is why when the blister is expanding, it will expand itself in a rounded fashion, and that is why all subepidermal blistering disorders like bullous pemphigoid, dermatitis herpetiformis, epidermolysis bullosa acquisita, epidermolysis bullosa dystrophica, you will see a rounded extension of the blister. Clear? Now, if you get an irregular angulated edge, that will be seen in pemphigus vulgaris. Now, Asbo-Hansen sign you cannot perform in a case of pemphigus foliaceus. The reason being that the blisters, first of all, are very rarely seen, and they are extremely fragile since the roof is formed only by the stratum corneum, right? So it's physically not possible for you to perform a Asbo-Hansen sign in a case of pemphigus foliaceus because it's a very fragile blister, correct? Now, also remember that you cannot do it in staphylococcal scalded skin syndrome for the same reason that in staphylococcal scalded skin syndrome, the blister is subcorneal, because again in staphylococcal scalded skin syndrome you have damage to desmoglein 1, but in staphylococcal scalded skin syndrome, or Ritter's disease as it is called, the blistering is not because of antibodies, okay? The blistering is because of the toxin which is released from the Staphylococcus aureus. Okay, so both of these conditions give rise to subcorneal blisters, and hence, since it's physically not possible to do so because the blisters are very fragile, once you touch them they break off, it's not possible to do an Asbo-Hansen sign, and hence it's supposed to be negative. Is this very clear? Let's go to the other sign which is called as the bulla spread sign. Okay, so what happens in this bulla spread sign? It is the same thing like an Asbo-Hansen sign, but the direction of application of pressure is from the margin. So here, if you see, this is a bulla. You apply, you apply proper pressure at the margin of the blister, and then you look out for the extension. So once you have marked it, you look out for the extension of the blister. And if you see that the extension of the blister is rounded, again that is suggesting a subepidermal bullous disorder, while if it is angulated, it is suggesting that it is a intraepidermal blistering disorder like pemphigus vulgaris. Okay, there is another very important sign which is seen in pemphigus, which is called as the Nikolski sign. Okay, what is Nikolski? Nikolski sign is that if you are going to apply lateral pressure on the normal skin around the blister, it will result in separation between the layers of the epidermis, and the dermis moves under the finger and shears off. Okay, so this Nikolski sign is positive only in intraepidermal blistering disorders. You do not get it in subepidermal blistering disorders. So remember, you get it positive in pemphigus group of disorders, you will get it positive in staphylococcal scalded skin syndrome, you will also get it positive in toxic epidermal necrolysis and Healy-Haley disease. I'll just elaborate a bit on what is the pseudo-Nikolski sign in toxic epidermal necrolysis. Now see, toxic epidermal necrolysis is a condition which is most of the times kind of a drug reaction. It's an acute emergency. It's a drug reaction in which there is widespread necrosis and widespread apoptosis of the keratinocytes. Okay, so here there is no damage to the desmogleins. Here there is no autoimmunity involved. It is purely damage to the keratinocytes because of the drugs. Okay, so what happens actually is that the entire epidermis undergoes necrosis, and hence in this condition also you will get a Nikolski positive, but you don't call it true Nikolski because it is not because of the damage to the desmogleins or the intercellular junctions. Okay, it is actually the epidermal necrosis which is giving rise to that feel of the epidermis, shearing off and the epidermis moving under the finger. Okay, so the feeling that you get when you perform a Nikolski sign in a patient of pemphigus vulgaris or any of the other conditions which give rise to a positive Nikolski sign is exactly the feel that you get when you are putting your shearing force on a potato which is boiled. Okay, the skin of the potato, you will feel it moving, okay, under your thumb. That is exactly what you get the feeling in Nikolski sign. Okay, it will also be positive in Hailey-Hailey disease. Now, what is Hailey-Hailey disease? Hailey-Hailey disease is a condition which is a genetic condition. It's an autosomal dominant condition in which there is a genetic mutation of the ATP2C2 gene. Okay, and this gene is expressing itself in the suprabasal layers, and this gene is responsible for the normal functioning of the calcium pump. So what does this calcium pump do? It is responsible for putting in the calcium from the extracellular location into the intracellular location, and this intracellular location of the calcium is important for the functioning of the desmosome. Correct. So if there is a genetic mutation in ATP2C2 which is expressed in the suprabasal location, and there is an abnormal functioning or no functioning of the calcium pump, what's going to happen? The desmoglein will not function. So that is why you will have separation of the keratinocytes from each other, which is called as acantholysis. Correct. So in Hailey-Hailey disease, you get incomplete or partial acantholysis of the entire epidermis, and it manifests itself as the presence of vesicles and bullae. So here as well you will get a Nikolski positive, and the typical kind of histopathological appearance which is described in Hailey-Hailey disease is the dilapidated brick wall appearance. Okay, so that itself can come to you as an MCQ. So I think we can end here. Okay, so just to kind of reinstate that I do have my complete course on on Unacademy of 19 hours. It has started off on 19th of July 2020 and will go on up to 31st of July 2020. I request all of you to enroll in this, and when you do enroll, please use the referral code DRResham10 and get a 10% off. I am very sure it's going to immensely benefit you, and I also solve queries, I also solve questions. Okay, and I hope this small lecture that I have taken, which was more concentrating on the pemphigus and other vesiculobullous disorder, will help you to solve a few questions on this topic. Okay, if there are any questions, if there are any comments, please post them in the comment section, and do follow me on Unacademy so that if there are any special classes, free classes that come in, you will be notified, and you can always attend them. Okay, so I think you've been a very good audience. Thank you very much. See you soon on Unacademy with my course.